My name is Olivia. I'm a social worker at the Ottawa Hospital's Cancer Center at the Psychosocial Oncology program. Let's get started. So just some logistics. I don't have any financial interests to disclose. In terms of conflict of interest, so there is compensation being provided from the Champlain Hospice Palliative Care Program, and the sum of those funds will be donated back to the Psychosocial Oncology Program's Patient Emergency Needs Fund. In terms of bias, we'll be discussing navigating difficult family situations in palliative care, but from a social work perspective and from an oncology perspective. Okay, so at the end of our time today, we'll be able to understand a bit more about palliative care and oncology. I'm sure that the topic of palliative care is something already near and dear to you, but we'll dive in more from the oncology side. We'll be able to name various frameworks in social work and oncology. We'll identify how people living with advanced cancer and people affected by advanced cancer cope. And we'll be able to recognize some intervention opportunities through some case examples of challenging situations. So I realize that Zoom has this huge benefits, but it can make for a bit of a disconnect. So before we get started, I just wanted to have a quick icebreaker. If in one word you could just describe your work using an adjective, or just if you could comment in the chat. And then hopefully Tara can read them out to me.
Sorry, it looked like there was a error with the chat. I've just opened it up, so now stuff should be coming through. There we go.
I don't know how to multitask on Zoom, so I won't even try to check it.
Okay, I'm going to read them out for you, Olivia. They're starting to come in now.
Yeah.
So we are seeing compassion, rewarding, quite a bit of rewarding, volunteer, creative, variable, passion, volunteer at hospice, home care, super multitasker, some more compassion and rewarding, emotional, comprehensive, independent practice, honor and privilege, challenging, some more volunteers, pastoral care volunteer, serving, great but exhausting, sad, fulfilling, and challenging.
Wow.
And one word has just come in, totally connecting.
Wow. I really appreciate hearing that and knowing that I'm not alone behind this screen. It's nice to, meet you all virtually. If I could describe my work in one word, I think it would probably be fulfilling. There's a lot of variety. There's never a dull moment. As I mentioned, I'm the intake coordinator at psychosocial oncology at the Ottawa Hospital's Cancer Center. I have a bit of a split role, I guess. Part of my role is as intake coordinator, doing kind of the triage of all the referrals that come to our interdisciplinary team. The other part is kind of carrying a clinical caseload and tending to emergencies. So yeah, very fulfilling. And I concur with what everyone's said. And it's, again, nice to be with you here tonight. Okay, so how do we define palliative care? So the World Health Organization says that palliative care is a crucial part of integrated people-centered health services, and it's relieving serious health-related suffering, be it physical, psychological, social, spiritual, and it's a global ethical responsibility. So per the World Health Organization, it doesn't really matter what the cause of suffering is, whether it's cardiovascular disease, cancer, organ failure, drug-resistant TB, acute trauma, etc. But really, the way that they define it is that palliative care may be needed in all spheres and has to be available at all levels of care. So we see that through the various lenses of palliative care, that the goal is to alleviate suffering. And of course, there's the symptom management piece that's really crucial for quality of life and all components of well-being. Won't be speaking too much about the symptom management piece, but more so on the link between the biological suffering and the psychosocial aspects of care. So the World Health Organization definition really aligns with the 5 main supportive needs of people who have cancer. So above and beyond the cancer symptoms, there's also the supportive needs. So informational, psychological, social, practical and financial, spiritual. So an informational need could be something like, what type of cancer do I have? What are the stats? What are the facts? A psychological need could be something, related to emotions and coping. Socially, it would be around, communicating with people within the care team, within our personal circles, connecting with peers that have a similar diagnosis. Practical and financial. So those are, the nitty-gritty everyday aspects of cancer care, the transportation and appointment scheduling and income support, medication coverage. And the spiritual aspects are relating really to the belief of meaning making and hope. So the person that has cancer has these needs that they're trying to meet, and their family members and their caregivers and loved ones also have these needs. So as they're navigating cancer, they're not just navigating the symptoms and the treatment, but they're also, trying to get these supportive needs met. So I mentioned that I'd be speaking to the link between, the biological aspects of suffering and how they relate to the psychosocial aspects of care. And I invite you to look at palliative care and oncology, but through my social work lens, and looking at it from a biopsychosocial perspective. So really the biomedical or the physiological aspects of cancer care can include, any of those examples: weight loss or weight gain, surgical scars, stomas, hair loss, pain, neuropathy, changes in mobility, fatigue, agitation, cognitive changes, chemo fog. And we know that, for example, with chemo fog or chemo brain, that it can cause challenges with memory and attention. And we know that this can be exacerbated by periods of high stress, which is interesting because then cancer is a pretty high stress period. So they kind of work hand in hand. In terms of the psychological aspects, so cancer can provoke changes in self-esteem, self-confidence, body image, can cause anxiety, low mood, all of those kind of invisible symptoms of cancer and the treatment itself. The social aspects of cancer can cause concerns, in regards to relationships, finances, job security, access to care and medications. So as we go through our examples today, try to bear in mind these factors, and they may come in handy in a pop quiz later. So some of these aspects touch on the realities of the social determinants of health. So for social work, or for social workers, social determinants of health are really our bread and butter. So for those that aren't familiar, again, the World Health Organization says that they're the non-medical factors that influence health outcomes. So the social determinants of health are the conditions in which people are born and grow and work and live and age, and the wider set of forces and systems that shape the conditions of daily life. So these forces and systems include economic policies and systems, development agendas, social norms, and social policies and political systems. So some examples of social determinants of health are factors like education, income, social inclusion or exclusion, job security, housing. And we know that the social determinants of health aren't the sole factors for a health outcome, but that they greatly influence someone's probability of being affected by one condition or another. So our first pop quiz. Now that you know briefly about the social determinants of health, how many do you think there are? 5, 10, or 14? Oh, do I get to vote too?
Are you able to see the poll, Olivia, as it goes, or?
Oh, I saw the question, but I didn't want to give the answer, so I X'd it out.
Okay.
Yeah, we'll give it another few moments for people to answer. It looks like most people have answered so far, and then I'll share the results with everyone. Looks like there's a mix of opinions right now. Okay, so I got the results shared there, and I'll just read them out for people who are watching the recording because they won't be able to get that pop-up screen. So it looks like most people are thinking it's either 10 or 14, and then a smaller amount of people think it's 5.
Okay, well, thanks for your participation, guys. So the Canadian Public Health Association recognizes 14. So 14 non-medical factors that influence health outcomes. So I gave you a few examples. Again, engaging you guys, can you share other factors that could be considered social determinants of health?
So I see age, family, income, isolation, ethnicity, location, education, bad habits, relationships, culture, support, language, race, disability, sexual orientation, culture, geography, gender.
Oh, you guys are totally on the right track. You're speaking my language. So
We had a couple more. I'll just finish them off. Olivia. Environment, access to service, and I think religion may have been mentioned before, but I'll say it again, and early childhood development.
Okay. Very well done. So, so here are the 14. I bring these up just so that you can recognize them through future interventions. And it sounds like you guys are already really recognizing them. But just to speak to these factors at play. So income and income distribution. So, in the context of cancer, will someone have the financial security to pay their bills if they need to be off work? Do they have the means to afford their medications? Do they have any coverage? Something like education. Does the person have, enough health literacy to understand the diagnosis being given to them? Employment and unemployment and job security. Will they have a job to get back to once treatment is done? Employment and working conditions. Are there any workplace factors that have contributed to their health, like exposure to harsh chemicals without, proper PPE protection, for example? Early childhood development, somebody mentioned that. So, what type of caregivers do they have as children? What are their attachment styles? What attachments did they have as a child? Food insecurity. So does this person have access to enough food and quality food to meet their nutritional needs? Housing. Do they have stable housing while they go through treatment? Social exclusion or inclusion, I guess. Are they a majority or a minority within their community? And how has this benefited them or put them at a disadvantage? Social safety network. So what supports does this person have to keep them going, to keep them functioning? health services. So do they have access to the supports they need? Do they live in a rural area that's maybe lacking palliative services? Aboriginal status. So how do they identify, do they have the recognized status from the government, which could then help them access programs and services? So gender and gender identity, how do they identify and how has that shaped their lives and health? The race, which race category best describes them, and are there certain risk factors for specific health conditions? So for example, we know that certain cancers affect women more than men, or one person over another. Race, which race category describes them, and are they at risk for certain health condition? And disability, so what are their limitations and abilities? So the social determinants of health can influence health outcomes, and if they can influence health outcomes, they can influence mental health outcomes and coping abilities and styles. So if you think about it, our own social determinants of health as healthcare professionals can really influence how we cope with our patient challenges. So what influences how we perceive illness, how we deal with suffering, and our biases, and what impacts our coping in general? So upbringing and family of origin is one, cultural values and history, societal, personal, and professional views on illness, grief, and loss, education or lack thereof, spirituality and or religious affiliation. So these are all factors that can influence our coping and patients and families' coping. So looking more at cancer, so who does advanced cancer impact? The short answer is really everyone. The patient, the family, their caregivers, their community, their neighbors, the healthcare professionals. And cancer can really challenge all relationships. And we know that, every family is different and everybody defines their family differently. And it doesn't really matter how you define your family, whether it's, with the people closest to you related by blood, or whether it's people who love and support you like friends and colleagues. But no matter the role played, finding out that either you're the person diagnosed with advanced cancer or finding out that someone you really care about has cancer often comes as a shock, and there's a shared sense of loss of control. And this is even more true in a condition where cancer is advanced or where treatment is no longer curative. So it can bring on, complex feelings and lifestyle changes. And it can really be an overwhelming time. And the effect on different relationships, it varies based on closeness of relationships, based on previous coping styles, but also based on, the dynamics within that family and what the dynamics were pre-cancer. So some people say that relationships get stronger and more meaningful through a serious illness. And other people say that, it takes a toll on relationships. So what does a palliative situation in the oncology world look like? So we know that when treatment is no longer curative, it can be considered palliative. We know that, the word palliative doesn't necessarily mean end of life, right? Because the actual definition is to palliate, to relieve symptoms, to ease burden without necessarily removing the root cause. So I refer to palliative care not only in an end of life circumstance, but really in that whole continuum of a lens of a non-curative disease. So what can it look like? It can look like getting long-term maintenance treatment or palliative radiation as an outpatient. It can look like an increased need for support at home with activities of daily living or instrumental activities of daily living. So things like maybe lacking the energy or strength to shovel snow, like a day like today, needing help with rides to and from appointments, needing assistance with meal prep or personal care. It can look like, admissions to hospital for acute changes in health status. It can look like a growing circle of healthcare providers. So the need for more allied health involvement and including the family physician more, or maybe being referred to a palliative care physician in the community or at the cancer center. It can look like being referred to government-funded home care or private home care. For some people, it's relocation. So relocation to a different province to be with family, to a different country to be with family. Or it can even be a relocation to a different type of care environment, like a retirement home or a long-term care facility. And of course, there's relocations to hospice type environments. And there's acute end-of-life periods, either through eventual death or through a medical assistance in dying. So regardless of the situation, it's really normal that family conflicts will arise. And I think that can make us as healthcare professionals uncomfortable, but knowing that, it's to be expected, and that intertwined in the experience of the patient and the family, there's grief. And through any palliative situation, there is grief. And it's really at the core of every situation with an advanced illness. So before going through some examples of difficult family situations, I wanted to touch on anticipatory grief and grief, because again, we can't talk about navigating cancer and navigating advanced cancer without touching on grief. So our patients and their families can experience anticipatory grief. So this is really the mix of feelings and thoughts and behaviors that come up as we anticipate death, as we know that it's on the horizon. But it can also be in response to various losses that occur as a person kind of approaches death. So you can experience anticipatory grief for yourself or for your loved one. And the difference really of grief is that that's, it's a natural response, and it's a response to a loss. And it can impact our thoughts, feelings, our bodies, our relationships, our beliefs. And, it usually changes and evolves through time, but it's really ongoing. And, we know that loss can arise from grieving the death of someone that we care about, but it can also be symbolic loss. And what I mean by that is that in any life transition, especially in the context of advanced cancer, there's loss of independence, and there's a loss of previous hopes of what we, had perceived for the future. There can be changes in roles and relationships, and how we perceive ourselves in our family circle. And cancer can bring on these symbolic losses for both the patient and the family. So again, knowing that this is really at the core of palliative situations in oncology is grief. So I'm sure you're familiar with the Kubler-Ross model of grief. It was initially published in 1969 and had 5 distinct phases. So there was denial, anger, bargaining, depression, acceptance. And since then, there's been other models developed, and people have added other stages like reconstruction or loneliness, distress, relapse, but most end with acceptance as kind of the final stage of grief. So the psychologist at our program at the Cancer Center, her name is Dr. Cheryl Harris, and she really preaches that we should stop thriving for acceptance in our patients and aim for adjustment and authenticity. And she says that, in conventional language, the term accepting really connotes that we're embracing something, and which certainly doesn't have to be the case with a terminal illness that we didn't ask for, right? So I think it also kind of feeds into this all or nothing mentality that's really prominent in the cancer world, that we're fighting and we need to accept it. And there's a culture a little bit of wanting to fix how other people are feeling and get through the bad feelings and get to the end of grief. So our expectations of our own grief and the grief that our patients and families experience don't always align with how, we anticipate or how we're expecting it. So the only normal thing about grief is that there's no normalcy. It can really vary from one person to another, as you see in this picture, what we want grief to look like and how it actually works. So just food for thought. I really love this quote. And this is one of the hardest things that we do as healthcare professionals, but it's to be present for another person's pain without trying to fix it. To just stand respectfully at the edge of that person's mystery and misery. So whether it's supporting someone through grief and loss, or through advanced illness, or in caring professions because we want to make someone feel better. We want to ease their pain. We want to soothe their symptoms. And sometimes it's possible, and other times it's not. And especially in circumstances where we're talking about emotional pain, we can't always take away someone's angst. So I think it's important for us to remember that it's not necessarily our job to change how people feel, but it's our job to meet them where they are. And only when and if they're willing can we point them towards resources and tools and empower them to learn adjustment strategies. Again, not acceptance strategies, but adjustment strategies. So not necessarily changing how they feel, but helping them live despite their challenging realities. So a few different case examples of questions that were brought up for today's session. One of them is navigating palliative care navigating family denial and in palliative care. And when families have unrealistic expectations or really unrealistic requests through their care. So I'm sure in hearing there's already some cases that come to mind for you. So first, we need to acknowledge that denial and avoidance are coping strategies. Are they ideal? No. Do they make our work more challenging as healthcare professionals? Sometimes. So there's really a fine line between maintaining hope and being in denial. Let's watch this short video of Lewis, and we'll get back to that.
Sometimes the family may have to be reminded again and again that about palliative care or in hospice. They are still thinking, especially when the patient is a younger age, they still want to have aggressive medical procedures, and they may blame the medical staff on why don't you use the most modern medicine or modern procedures to save my loved ones. Okay, but when they are older patients, usually the attitude is not there. Okay, the other thing is about funeral. About half of the families that I came across would not have any funeral arrangements until we start talking to them. Then they would start start to get preparation. I believe is they still, on the back of their mind, they still has hope for a recovery.
So that concept of denial that Lewis is speaking about, it's an example of a maladaptive coping strategy. And basically, we learn how to cope with the world and its stressors, we start learning anyways in childhood. An example of a coping strategy that we start learning is, a baby sucking its thumb. It's looking for self-soothing, and it's learning how to cope with that distress. So through childhood, our strategies change, and maladaptive coping strategies come up in situations where our usual techniques just aren't working. So in situations of significant stress, it can cause us to lean on these maladaptive strategies when the strategies that we usually use aren't working for us. So it's not these aren't strategies that are meant to be utilized forever, but in a short period, denial or, a bit of avoidance or delayed attention can actually be really beneficial. It can quite literally help us focus on what's in our control and turn to a problem-solving approach. And it can help us, temporarily avoid thoughts and feelings while we're trying to get some really practical things done. So, it can help us get through initial stages of treatment when we were just diagnosed with a metastatic disease. It can help us plan a funeral for somebody that passed away unexpectedly. But again, these aren't strategies meant to utilize forever, but just to say that, denial and avoidance serve their purpose.
Olivia, can I just jump in for a second?
Yeah.
Just a couple of comments in the chat box before we get too far away from denial. So one of them was that sometimes denial comes from the patient. There's another one that's sharing that in long-term care, sometimes there are ageism complaints, right? It's like, and then finally, there's one last comment. There's a sharing in response to what you just said. That's a great viewpoint, looking at what purpose denial can serve.
Mm-hmm. Yeah, thanks for those comments. Certainly ageism, that was probably a comment maybe of the social determinants of health, but absolutely, there's a lot of ageism in healthcare, unfortunately. And agreed, denial can come from the patient themselves, right? And it can come from the family members, but I think, again, that it can serve its purpose, but it's not intended to be utilized forever. So if we use this as an analogy, if you think of a beach ball and you think of your emotions as a beach ball, and you're standing in the ocean and you take your beach ball and you push it under the waves, you can probably keep it there for a while, but eventually it'll kind of plop back up to the surface and splash you in the face. So again, just all that to say, it's not always a bad thing to temporarily set emotions aside to help us cope. But eventually, just like that beach ball, our emotions come back and they want to be felt, and they kind of gnaw at us. And if we ignore them, they can kind of transform and grow. So it's just to say that those, it's okay to set them aside, but eventually we need to give them the attention that they're looking for. It's also, I think, important for us as healthcare professionals to acknowledge our own personal biases towards patients and families who are in denial. We think maybe, well, when my father was sick, I did blank. Or when this happened to my last patient, they coped like blank. So I think we can label people as being difficult sometimes, or avoidant, or maybe unrealistic. But, they're viewing their circumstances from their lens, and it's not always something that we can relate to, right? So I think just important for us to recognize our own biases in these cases. Sorry. I'm not sure how to advance to the next slide.
We'll see if Carl hops on and fixes that.
Sometimes.
Here we go again.
I think if you look down below, Olivia, there's really faint in the bottom left corner, an arrow moving.
Oh, yes.
You see it? It's hard
Thank you. I appreciate that. Sorry, guys, very Zoom naive. So let's go through a case example. So Stephanie was a 21-year-old university student studying health sciences. So she was diagnosed with breast cancer, which had metastasized to the lungs, liver, and brain. So her father, Tony, was of Italian descent and of strong Catholic faith. Stephanie's mother had herself died from cancer 5 years prior. From the time of diagnosis, Tony refused to discuss any scenario other than his daughter being cured of cancer. And this was really despite the team members having a unified approach and consistently sharing that this was not a curative condition. So we spoke earlier about some factors that can impact our coping. So which of these factors is not a factor here? So upbringing and family of origin, cultural values and history, spirituality and or religious affiliations, education, societal, personal, and professional views on illness, grief, and loss. So which of those factors is not a factor here?
So it looks like most people have answered so far, but I'll just leave it open for a few more moments for other people. But it's looking like about 60% of people are thinking education or lack thereof. And then next is 22% saying societal, personal, and professional views on illness, grief, and loss. And then the other three are kind of split between about 6% of people saying split between upbringing, family origin, cultural values and history, and spirituality and or religious affiliations.
Yeah, so I appreciate your participation. I think education is probably the only factor that wasn't really glaringly obvious, but it may have been a factor as well. But really upbringing and family of origin and cultural values and history. So Tony's upbringing may have led him to have certain, views of cancer and advanced illness. And we learned from Tony that in the Italian culture, even talking about cancer and death could be seen as bad luck. Spirituality, well, we know that he's of strong Catholic faith, and this may, impact his coping in different ways. His personal experiences of grief and loss, he lost his spouse to cancer, and now his daughter is faced with, the same life-threatening illness. So in this case, the outcome, there was a lot of resistance from Stephanie and her father to discuss clinically appropriate treatment plans. There was challenges in discussing with Stephanie what her actual treatment wishes were and what her end of life wishes were. And, unfortunately, Tony was left with having to make really challenging decisions after his daughter lost capacity and then when she could no longer communicate her wishes. And that was a huge decision-making burden on him while he was in the thick of grief and even after Stephanie's passing. And in this case, the attention was really steered away from her and kind of the light was shined really on her father. Another kind of outcome was that they lacked supports like the palliative care provider at home because of the negative connotation associated with having, a palliative doctor. They didn't have proper equipment in the home because they didn't feel like they needed the bedside commode. But there was falls, there was caregiver burnout. And I think the bottom line, we approached Tony and Stephanie with kindness and compassion, and we recognized and acknowledged how terrifying it was for them to have to experience this, especially in the context of Stephanie's young age and what had happened to her mother. And I think we recognized that we may or may not have been able to change their views. But that if we couldn't change their views, it wasn't necessarily, a reflection of our clinical efforts. So, we presented the information, we kept supporting them, we tried different approaches, but ultimately, the care needs really have to focus on what's realistic and what the patient and the family wants.
Olivia, is it okay time for me to jump in with a couple of comments from the chat box?
Yeah, please.
Okay, great. So there's one, a question, how to deal with this case as a healthcare provider. It can be very frustrating as a healthcare worker. How do I not let my own frustration get in the way, especially when a family member, when family members overshadowing the patient? Been in similar scenarios.
Oh, great question. I don't think, our own frustrations are human. And I think that that's to be expected. So we can't necessarily expect that from ourselves to brush off maybe that irritation. I think where we can kind of weave that in is maybe not letting it shine, too brightly in our interactions with the patient and the family, having an outlet for that within the team. And, really trying to hone in on our compassion for these people and really trying, to be empathetic towards them and how would we feel if this was our situation, right? Remembering, that the aspects that impact people's coping and the social determinants of health, and their mental health state all kind of come into play. One thing, as I'm sure you're aware of, but around, expectation management, I think in cases like this, it can really be a winning strategy, to tell somebody, you can expect this from your care team, but unfortunately we can't do this because of blank, right? I think patients and families will try to push back sometimes, but knowing that this doesn't always come from a malicious place. And this is really where we need to flex our compassion muscles. Sometimes there's some trial and error. And I think that trial and error or trial and fail, this doesn't always sit well with us, right? But I think if the patient is capable and they're agreeable, they're allowed to make, poor choices. So example, when we were recommending that bedside commode and they were really resistant, they're allowed to make poor decisions or decisions that we perceive as poor. So, we can work with them on a plan and we keep, reassessing that plan and, eventually hope for a change in decision or a change of strategy. Another kind of strategy that works is case consultation, right? So having that outlet, debriefing with colleagues, keeping the lines of communication open with the patient and the family, but also kind of it branching out. So expanding that line of communication with the home care team and the primary care provider so that it doesn't all fall kind of on you as an independent clinician. In this case, actually, we had consulted with ethics and patient relations was very involved to try to support us within our role. But also, it can be helpful when we're stuck in trying to determine the next steps. And if we're wanting to ensure that we're following the hospital policies and we're also being mindful of the medical legal aspects of care, right? And family meetings, they can be time consuming to coordinate sometimes, but it can be a really helpful way to get everybody on the same page. Well, as close to on the same page as possible, everybody to kind of present their viewpoints, I should say, and then kind of work together on next steps.
Thank you, Olivia. That was a thoughtful response with good ideas and awesome reminders. There's just one other comment that maybe you have a response or a reaction to that a couple of people have shared. Going back to the last poll, I think it's, so the comment is, I felt really like all of the options were factors. Stephanie being in healthcare may have created some educational issues.
Yeah, that's true. having worked in health sciences, that could be a factor in, what she knows or what she thinks she knows about her condition. And we know that sometimes healthcare workers were the worst patients. So for sure, you're right. It could have been a factor as well. So another challenging situation for us to navigate as healthcare professionals is when family members don't want the patient to know the diagnosis or prognosis for that matter. And they're asking staff to keep it from them. So we'll tease through this with the example of Fahid. So Fahid was a 78-year-old Urdu-speaking gentleman from Pakistan. He'd been in Canada living with his daughter Ali for about 10 years before he was diagnosed with a GBM. So Ali was adamant that her father's diagnosis be kept from him. She did not want him to know about the cancer, but she was really keen for him to start radiation and oral chemo as soon as possible. She wanted to help reduce his symptom burden and prolong his life. So what do we think? What do we do in this case? Do we have to respect Ali's wishes and we bypass Fahid? Or we have to tell Fahid, it's his diagnosis, it's his care. What would we do?
So I'll leave it open again for a couple more moments for people, but most people have answered, and 88% of people said that we have to tell Fahid about his diagnosis, it's his care, and 12% of people said we have to respect Ali's wishes and bypass Fahid.
Yeah. So thanks for that. And in fact, it's a tricky question, but it's a little bit of both. So from a professional and practical standpoint, comes down to consent and capacity. So Dr. Lisa Walker, she's a neuropsychologist at the Ottawa Hospital, and her and her colleagues, they say that a patient can defer decision making to a substitute decision maker or to a power of attorney, but they can't be kept completely out of the loop. So no matter, how well-meaning the family is. So health information belongs to the patient. So if the team approaches the patient and the patient says that they don't want to know and they prefer the professional to address their family, then that's okay. As long as the patient is capable to make, that choice, and as long as their power of attorney or substitute decision maker is okay to, step in as a decision maker for them. But they can't bypass completely the patient, even at the request of the family. And, the Substitute Decisions Act in Ontario, it states that, personal values and beliefs need to be taken into account when we're deciding on behalf of someone else. So this means that, if Ali is deciding on behalf of Fahid, she has to decide in his best interest, yes, but also based on previously expressed wishes and in conjunction with his values and his belief system. So, of course, we need to be sensitive to values and beliefs, right? Ali's stance could be for cultural reasons, for religious reasons, but first, before applying the law, we need to acknowledge as practitioners that there may be, a component of wanting maybe to shield family members from that pain. And there can be, a culture of privacy or not wanting to worry the loved one. We can also use curiosity. If we're not familiar with the reasoning behind, Ali's resistance, we can, have her educate us, why is this a factor for you? Where's the resistance coming from? So we'll watch a short video of Dr. Dosani. He's a palliative physician who speaks about this challenge.
Sometimes we get scenarios where loved ones or caregivers say, you know, can you not talk about this with mom or dad or my brother or sister or my husband or wife or partner? And that gets really difficult. You can imagine a big part of the palliative approach to care is having conversations about advanced care planning. And if we're told not to do that, that can get very difficult. But often when people are saying that, there's a reason why they're expressing that to a physician or a nurse or a healthcare provider. There's something within themselves that they are worried about. Perhaps they're scared. Perhaps they themselves have never had those conversations and are nervous about how it's going to go. So tracing it back and getting a better sense of where that person's coming from allows us to better understand why advanced care planning is so taboo for that individual or for that family. Maybe it was because they had a previous experience with death that was very difficult, or perhaps it's just so new to them they just don't want to embrace it. And so these are things that we try to tease out so that we can have the conversation. So yes, very complicated and it can get very complex when you know we're kind of getting a message to not have those conversations. At the end of the day, as a palliative care physician, it's my duty to have these conversations with patients and caregivers, but to have them in a sensitive fashion that meets the needs of the patients that I serve and their caregivers in a way that's upstream as well.
So, you know, in terms of winning strategies, you know, like Dr. Dosani was saying, really trying to understand the reasons for their resistance, using curiosity and, you know, having open discussions. In Fahid's case, another winning strategy, you know, is care in the mother tongue. So, you know, trying to eliminate any language or communication barriers. So Ali may have the capacity to be the interpreter here, but it may be a biased interpretation. So I think in a perfect world, there would be a third party interpreter. And of course, you know, mindfully acknowledging traditions, rituals, religious views, spiritual practices. And, you know, we can consider expanding the circle of care. So in some situations, you know, patients and families, they have a leader through their place of worship, for example, who's previously really helped support them through challenging times. So is this, you know, a leader that we want to engage in their care that would help them cope better, that would help them, you know, adjust better? And, you know, again, I think sometimes we need to consult neuropsychology, ethics, again, patient relations, and utilizing, you know, all of those services available to us.
Olivia, can
Yeah,
I pop in with a couple of questions?
please.
Okay, so the first one, someone has asked, what about the patient who doesn't want to tell the family?
Yeah, that's a good question. It's true. It can go both sides. I think it's tricky because, of course, you know, it's their information and it's their prerogative with who they want or don't want to share it with. Where it gets tricky is where, you know, if they're leaning on family for care, or they need a ride to their appointments, or they're at a period where, you know, they're needing more help at home, then having that discussion can be really imperative. And again, I think it's trying to get a sense from that person, you know, where does that resistance lie? Why is that resistance there? And working with them to, you know, help them share that information when they're ready and if they're ready.
Thanks, Olivia. And there's one other. Someone has asked, how would you lead a family meeting about this case? What questions would you ask them? So going back to your previous.
Yeah, well, first, I think having an interpreter present, a third-party interpreter would be ideal. It's tricky because, if I introduce myself as a social worker at the cancer center, then the patient would kind of catch wind in that circumstance. I think, first of all, I wouldn't lead it on my own. I would try to really expand that circle, maybe having, the interpreter present, other family members, the physician, there's other members of the allied health team, and try to kind of explain, what our responsibility to the patient is first and foremost. And of course, again, if Fahid says that he wants us to bypass him and he wants us to chat with his daughter, then that'll be his prerogative. But again, first, broaching the subject with him.
Yeah, and Shirley's just pointing out it's likely going to be more than one meeting.
Absolutely. Yeah, these things, as you know, they take time and they're very delicate. Yeah, thanks for your participation. Really appreciate it, guys. So communication with angry families. So we spoke about how families look different and how, one person's family is maybe blood relatives and another person's families may be, people who love and support them. In any family, there's unspoken rules. So an example of this could be, in our family, no one talks about negative emotions. If you're sad or you're angry, you keep it to yourself. Or in our family, we don't talk to each other when there's issues. We talk to mom, and mom disseminates the information. Or, our Aunt Julie, she's really quick to emotion and we really try to shield her from the hard stuff. Or, our cousin Amanda, she's always the first to pick a fight. Or, our dad, well, he's the one, he's responsible for mowing the lawn and the outdoor maintenance. These are kind of unspoken rules within families. So the volume of unspoken rules really increases when somebody is diagnosed with a terminal illness, and parameters sometimes need to shift. So, this happens as people are dealing with strong emotions in their own way and, considering what the future may look like for them or for their loved one. As people move, willingly or unwillingly into different roles that were previously occupied by someone else. So, if dad can't mow the lawn anymore, is that a task that I'm going to take on, for example? And, the family members kind of work within the established roles and rules and maybe trying to push them a little bit. So, in palliative situations, we want to bear in mind that people have their pre-existing ways of coping as a family, and it's expected that communication may break down. And we want to keep acknowledging for them that, these are frustrating times. There can be a grief response, and sometimes just naming for them that this is a grief reaction can be therapeutic. And of course, some basic examples of how to deal with angry patients and families. We want to give them time, uninterrupted time if that's possible. Really listen actively, give them time to vent and let out what they're experiencing. We want to be mindful of our body language and how we come across. Sometimes, we can try resisting matching their tone if they're getting angry and kind of escalating. We really want to dial up the compassion. We can paraphrase to clarify, what our understanding is. Sometimes, when appropriate, we can apologize on behalf of the healthcare system, on behalf of the team. And I think ideally trying to end interactions with a game plan or, what are our next steps? Maybe this is setting up a follow-up appointment or referring them to a counselor or, a specific support like a unit manager or the patient relations contact so that they can give their feedback. But I think, at a baseline, we can eliminate barriers in communication by using, proper and relevant terms. So especially in cancer care, using the word cancer. For some people, especially with lower health literacy, words like malignancy and mass and tumor it may not come across the same way. So really using that words, and I think, it helps eliminate some of the taboo associated. And language is important in palliative settings because families are already struggling with so much uncertainty. The patient's already facing so much uncertainty that I think, we can try to be as clear as possible with them about what they can expect. And of course, the caveat to this is if they have a particular, resistance or aversion to certain terminology, well, we can, meet them where they are and call it what they would prefer. And I think the same thing goes with death and dying. We live in a very death phobic society, and we use terms like passed away or resting in peace instead of saying dying. So I think we tend to use euphemisms as a way to soften language, and maybe it's a way to also soften reactions. But I think at the very least, we can try to give them clear information on what to expect about prognosis, of course, if this is something that they're willing to discuss. So communication in general in the healthcare system, as you know, it's a challenge. One hospital has done this, the other hospital has done that. We have different information management systems. We can't see what the other hospital has done. We're not sure what home care is working on or what the family doctor knows or doesn't know about how the patient is coping. So this breakdown in communication and, that continuity piece is really, an ongoing challenge. And unfortunately, I think patients and families are sometimes caught in that crossfire of this challenge, even for us. So we have to ensure that we take time, for thorough chart reviews, and that we connect with colleagues to be on the same page. And we communicate with providers outside the organization. And then, in an effort to give the patient and families, consistent and unified messaging. A lot of people give the feedback that, they don't know what to expect in their care. A lot of people say, I didn't know that this was going to happen, or I didn't realize that, I was being referred to an oncologist, or I think sometimes it's that the physician is properly explaining and the person is just not retaining the information. They're overwhelmed. There's too much going on. But sometimes also maybe jargon is used, or conversations are rushed, or, people often say like, why can't I just speak to my oncologist when I call? Or why do I need all these scans? Why hasn't anyone told me, how much time I have left? So I think, we can eliminate a lot of frustration by giving people the lay of the land, what they can expect in their care, who to call for what circumstance. And again, coming back and asking them, what they're wanting to discuss and when. And we can really try to foster this through our care with patients, especially we all know the time constraints, but if we say, okay, today we have 15 minutes together, I was hoping to review this. What were you hoping to touch on? And, do you want to talk about prognosis, or do you want to talk about next steps in your care, and kind of taking the patient where they're at, but setting the expectation right off the bat, how much time you have, what your kind of agenda or goals are, and then what their goals are as well.
Olivia, we have a really specific question in the chat box if you have time to answer it here.
Yeah.
So the question is, what should I do if a family member is really in my face or confronting with their anger? How to de-escalate? It could be hard.
Yeah, well, I think some people, it escalates so aggressively where it becomes inappropriate, right? So of course, I think if it's in a situation where you're fearing personal safety, or where you feel that, your boundaries aren't being respected, we need to utilize security. We need other colleagues aware. We need to have the door open. We need to be by the door for kind of a quick escape. Recognizing that, patient care is two-sided. And of course, we have responsibility, but patients and families have a responsibility to treat us with respect as well. So we can't do that at the detriment of our own safety. So moving a little bit away from communication with angry patients and into communication with kids about cancer and end of life. So a quick poll. So what should we promote to patients and families? Do we tell them, talk to your kids about cancer and be honest? Do we say, don't talk to them about cancer, death, and dying? Or do we tell them to hide their emotions from their kids?
Okay, so it looks like most people, about 94%, are in agreement that we should talk to kids about cancer and be honest. And then 3% are thinking, don't talk to kids about cancer, death, and dying. And 3% say hide your emotions from your kids.
Yeah. So the recommendations are to promote talking to kids about cancer and being honest. So at our program, my colleague Janelle, she runs a class called Kids Matter. Let's talk about it. So it's an educational class, and it's intended for parents or grandparents on how to talk to kids about cancer and how to approach the topic of death and dying. And it's a frequent reason for referral to our program. It can be such a challenging part of helping people navigate a terminal illness. So of course, depending on development age of the child, the recommendations will vary. But generally speaking, experts say that we should talk to kids about cancer early on and, be clear about the information that we provide. So for us as healthcare professionals, we can encourage our patients to have discussions with their children and to, explain to them that engaging their children in these conversations can help them feel secure and can help them feel, like a valued member of the family. And a lot of parents, report that they feel a sense of relief after these initial discussions have been had. And I think a lot of people steer away from showing emotions to their kids out of fear that it'll scare them or, they want to be strong for their kids. But it's okay to encourage our patients to be authentic. Again, that authenticity piece. And if, they're showing their kids that they're able to authentically show up with their emotions, they're also modeling for their children what healthy expression of emotion is. And it signals to their children that it's also okay for them to share how they're feeling if they're having a rough go. Of course, we can also tell our patients that, they may not have all the answers and that their kids may have questions that they're not able to answer, but that it's okay. And that we, I think with everything in life, can't shield children from all the hard feelings. And I think it's important to recognize just how resilient kids are and that they can really benefit from being part of the conversation. And along those same lines, when it comes to death and dying, talking to them about death and dying, even if cancer is not a factor in our lives. So normalizing the natural life and death process can help eliminate some of the death taboo. And in a lot of ways, I think can help people live more fully, right? And children are usually really curious about death and what it's all about. And specifically around death and dying, the recommendations with children are not to use euphemisms, but to be very clear, saying that, grandma's resting in peace can be confusing. So really using, proper terminology. But of course, recognizing that parents are the experts of their own children. So they, probably have a sense of what their children can and can't tolerate.
There's a comment, Olivia, in the chat box that was shared, and it's that it could be very traumatic for children.
Oh, for sure. And, kids are very intuitive, right? And if there's cancer happening at home or there's changes on how their parent looks or how their grandparent looks, they pick up on that. But I think sometimes if we don't acknowledge the elephant in the room, that can kind of grow, and then it doesn't help them feel, secure, despite all the challenges that they're observing.
Yeah, absolutely. There are just a few others, Olivia. Someone has said that it's really important that children are offered therapy so that parents aren't their sole support systems.
Absolutely.
Yeah, there's another comment that one of the kids that I saw at a healthcare center was playing with dolls and saying one of them had cancer and acting it out.
They're so creative and how their little minds work. It's really inspiring to see how kids cope in comparison to adults.
Yeah, their way of working through it.
Yeah, it's really exceptional. And along those same lines of, the parents not being the sole support, there's guides through the Canadian Cancer Society. There's literature that can help, the parent or the grandparent really, have a step-by-step information on, how do I broach this with my kids? So those are really, nice resources that we can share. Another one in Ottawa, through the Ottawa Regional Cancer Foundation, they have a class or a support group, I should say, called CLIMB. It stands for Children's Lives Include Moments of Bravery. So it's a free program. It's for kids between the ages of 6 to 12 whose parent has cancer. And it's to help them, process their feelings and enhance their abilities to cope.
Thanks, Olivia. And I'll just throw in one more resource that I love, which is kidsgrief.ca.
Yes. Oh, it's so good. So good. Also, and mygrief.ca, the equivalent for adults, but those websites are priceless.
Absolutely. And one last comment, someone has mentioned that kids, as you did also, kids are very sensitive to their surroundings. So they're already picking up on things.
Exactly. Yeah, naming that elephant in the room. So another challenge in palliative situations is incorporating family members' wishes into patient care without affecting the patient's wishes. So often this occurs when we're at a bit of a crossroads, and I think sometimes we can accommodate family wishes without it impacting the patient's care, and other times this can be challenging. So sometimes it can be as simple as, changing a chemo appointment so that the daughter who has a day off can accompany her parent on the day. And other times it's more complex. So if we look at this case example, so Richard, he's a 68-year-old man with rapidly progressing lung cancer. So he's always been vocal about not wanting to burden his family with his care needs. So even before cancer, he was the type of guy to suck it up when he felt unwell, and it was never in his nature to ask for help. So when his functioning started to change and he started noticing the impact on his family, started talking about moving into a retirement home and initiating the process for medical assistance in dying. So his family members are adamant that they can continue supporting him at home, and they're strongly trying to discourage MAID. So on weekdays, he can, require assistance from 2 people for transfers and support with personal care. He has some support through home care, but feels it's not enough. And his family members are becoming caregivers, which is really changing their dynamics. He wants to leave home to get the care he needs and avoid burning out his family, but his family doesn't agree. So if we look at Richard's wishes, so they seem to be aligned with long-standing values of independence and wanting to be as independent as possible. He doesn't want to burden his family, and he wants to die on his own terms. So, he's trying to set up a system that eliminates some of the caregiver duties on his family, and maybe hopes to just have his family be as they are and enjoy quality time together and not have to be those caregivers. If we look at the family's wishes, they want to take on Richard's care. They don't want him to relocate. They want him around for as long as possible. And, we need to bear in mind that for a lot of caregivers, they report that there's a lot of meaning in caring for a loved one who's sick. And it can be rewarding, and it can kind of give a sense of some control in a circumstance where there's a lot of lack of control. So in this example, both perspectives seems value-based and, coming from a place of love. So how do we incorporate the family member's wishes without affecting Richard's wishes? So we can note to our patients that it's ideal to remain flexible in their plans and how things will unfold, and that this can help, avoid feelings of regret or guilt, depending on outcomes. So, in a situation like this, either Richard or the family has to bend a little bit. So one strategy could be to kind of trial and error for a set period of time and then plan for a reassessment. So this could be, for example, Richard staying home for a month, really maxing out home care supports, and maybe initiating the process with medical assistance in dying. And after the month, seeing, what does his quality of care look like? What's his, perspective? What's the family's perspective? And in that month, the family could also maybe try to educate themselves on medical assistance in dying and how that process works. And again, after that month, kind of reassessing where everybody's at. And in a situation where, the patient is opting maybe for wait and watch, or instead of pursuing treatment, or is choosing to withdraw treatment, or opting for medical assistance in dying, it's normal to have conflicting wishes and mixed feelings about the right thing to do, or sometimes the ethics can come into play. So in this case, the caregivers were available to provide the service. They're available to provide the care. Other times, as you know, sometimes caregivers can't because they have to work, they can't afford to be off work, they're either not available, they're not willing. They have other responsibilities, like they have young children of their own that require their care. And, another limitation in an example like this can be, as you know, that, home care supports can sometimes be less than what the patient and family perceive they need. And some people have the means financially or private insurance to kind of supplement care. In other circumstances, it's not an option. But it can become really complex. And, I think through COVID, we saw this where even private agencies were lacking human resources, and setting up somebody for, successful care at home could become a challenge. So I think in terms of incorporating family members' wishes, we also need to acknowledge, I think our own expectations as healthcare professionals. Of course, we want the patient's needs to be met, but we also need to recognize, they come as a unit with their families often. And we can't, respect the family members' decisions at a detriment of the patient's. So we keep communicating, we acknowledge, we explore, we trial and error, test the waters, and of course, we continue assessing through the tough decisions.
Before we move on, Olivia, could I jump in with a couple of things in the chat box?
Yeah, please.
Okay, so there's a question. If neither party bends, patients' wishes would trump families, no?
Yes, of course. Yeah. If they're a capable adult, then yeah.
Okay. A comment, the time when they're caring for their dying family member may give them the time to accept the natural death or MAID.
Yeah, it can be a really meaningful time, and it helps with that adjustment, right? Like it literally gives them time to adjust to that new reality and to grieve or have that anticipatory grief period.
Thanks, Olivia. And one last one. Even with financial means, the staff is not necessarily available.
Exactly. Yeah. And I think through the pandemic, even people that said, I have all the money in the world and I'm really ready to hire privately, the human resources are sometimes lacking. So, in a situation where there's, heavy care needs for somebody who's at home and an outpatient, for example, that can become really challenging. So an interesting question that was brought forward as a discussion topic for tonight was how to get the family to accept they no longer need to feed the dying loved one. So probably the best person to speak to this is a physician or a dietitian or a nurse. I won't speak to so much of the reasoning behind it, but more the psychosocial aspects. So discomfort and disagreement from family when it comes to end-of-life nutrition is really common and it's to be expected. Food is really social. And if you think of it, we know that nourishing food fuels our body. We know that feeding a child or a baby helps them grow and develop. When we have a celebration, there's food. When we have a funeral, there's food. And food can hold a really special meaning in a lot of cultures. So it's a very symbolic loss when a loved one is no longer eating the way that they were. And the discomfort associated with this change can be a grief response. Again, families are grieving, the changes that they're seeing in their loved one, and they're seeing just another aspect of them change. So we know that people with serious illness may not be as hungry as they once were, and that they may become, full more quickly. And sometimes, it can help to entice the patient, with favorite foods or flavors. But we know that we shouldn't force someone to eat more, especially, if they're closer to end of life. This can actually, make them uncomfortable, cause symptoms that we're wanting to avoid. Reduced appetite is really normal when end of life is approaching. There's a reduced desire for this. There's different hunger cues happening within the body. There's a change in the body's nutritional needs. Sometimes it feels like, it just takes too much effort when there's already lacking energy. And eventually, people may be unable to even take medications orally, and they need to be administered in a different way. So I think we need to provide patients and families education that this will happen, and acknowledge that it's really hard to bear witness to, and normalize that it's really a part of the dying process. We can share strategies like, introducing sips of fluids through a straw or a spoon or ice chips, and promoting, lip care or with lip balm or mouth care with a moist sponge. That can be really, comforting for that person. So we'll just watch this short video of Sophie who speaks to this.
Food is big to everyone. Like, you want to bring food, you want your loved one to eat, they're hungry, they haven't eaten, and things like that. So that's something I explain as part of the disease process. Like, when you're preparing to die, I said, you no longer will be hungry. I said, it's not that they're starving and you think they're starving there. I said, they no longer have that feeling, and no, they're not starving, and all that. So I said, explain what to expect. These are the changes that are going to happen as we're progressing to the final day, so that they're aware, and when things start to happen, then they're ready. I mean, well, as ready as you can be, but informed, I guess, would be the better word.
So again, we see the importance of, providing this education and having those conversations as early as possible to help manage people's expectations.
Yeah, if I could just jump in there, Olivia, a couple of things. So yeah, people recognizing that families worry that they're starving, and it's uncomfortable, right? When family members aren't eating. Some people, I guess, are more, open to that. So April shared that her dad stopped eating. He would sit at the table with food in front of him, but wouldn't eat. But she shared that it was nice to have him at the table, but they knew that he wasn't going to eat.
Yeah. incorporating them still in that social way, and you know, having your expectations be realistic of them, which is really nice.
Absolutely. And then there are a couple of like really helpful things to share with families, a couple of tips. So one is saying that they're not dying because they're not eating. They're not eating because they are dying.
Yeah, well said.
Yeah. And then another one that's sharing that she tells people, it's like when women are in childbirth, you're not hungry. The body's
Yeah.
other things.
Yeah, your body's focused on other things. Yeah, thanks for sharing that. Oh, end of life conflicts. So it's really normal, again, through end of life, that there will be conflicts, especially if there was conflicts before cancer. You know, we spoke about those unspoken family rules. There's also unspoken rules about, you know, illness and dying and what that looks like in one family to the other. What I've noticed is that people, you know, sometimes as end of life is approaching, sometimes people kind of have this expectation that it may change with their relationships for the better. You know, like it is in the movies, you know, people say, you know, I thought my daughter would step in more. I thought it would bring us closer. I thought my brother was gonna do this more, do that more. And sometimes it's the case and it does bring people closer together. Other times it doesn't. And we see that people go through cancer the way they go through life, and that relationships, you know, often reflect the way that they were, you know, pre-cancer. So, you know, if you had solid communication and you were very open and proactive within the family and organized, that may be the way you go through it, versus if you had you know, a lot of strain in relationships and maybe were estranged from family or lived very marginally, that could also be how you go through cancer and end of life. So other than kind of historical issues of challenges, another one is kind of differences in coping abilities and coping styles, like we've seen. Also kind of division of labor of who's handling which tasks. And, you know, this can sometimes grow resentment if people feel that tasks aren't being divided equally, and can lead to caregiver burnout, of course. Another factor can be, you know, the presence of any pre-existing mental health conditions within family members or within the patient themselves. There was a study conducted in some ICUs that found that conflict amongst family members or between family members and staff they occurred in 78% of the 102 cases, you know, evaluated. So in most cases there was conflict. And another study showed that there was a higher rate of hostility from adult children as opposed to the hostility from a spouse or from the patient themselves, which is an interesting stat to consider. So with all this said, I think, you know, as clinicians, we can't expect or be expected to unpack decades of longstanding challenges and fix relationships as end of life is approaching. I think one thing to ask ourselves is this discord impacting care? If so, what aspects is it impacting? What's within my control to change? Or is it just kind of making me uncomfortable and maybe igniting like that fix-it mode in me? So again, in some families, this is really baseline. So we'll look through an example. So Denise was a 65-year-old woman who had lived an adventurous life. She'd lived in many countries. She'd secured housing in Ottawa after facing homelessness and lived through many traumas. She'd been in a relationship with Sharon for many years, but they lived in their respective homes. She had 3 sons. She was estranged from one and had a strained relationship with the others. As she was approaching end of life, there was questions raised by her son, Dan, about her will and power of attorney. So Dan felt that his brother Shane was unfit to be the power of attorney and executor of her will, and was saying that he was financially abusing their mother. So what's our role here? We need to call police and flag elder abuse. We need to continue assessing Denise's decision-making capacity, or do we need to hold a meeting and encourage her to change her POA and update her will?
All right, so it looks like most people have answered, and we have, oh, sorry, a bunch more just came in, so it just switched the percentage a lot. Okay, so we have 8% of people saying that we need to hold a meeting and encourage Denise to change her POA and update her will. And we have 5% saying we need to call the police and flag elder abuse. And 87% of people say that we need to continue assessing Denise's decision-making capacity.
Yeah, so I think what we would do here is we would continue assessing her decision-making capacity. So in this case, we were involved early in her care, and we were able to provide, the psychoeducation around the substitute decision-making hierarchy. And we're able to make the recommendations that it's ideal to have a will and a power of attorney. And she was able to complete this. And she did so with her lawyer's support. And it's really, this is an ideal situation where somebody can finalize these things before there's a risk of their capacity changing. So in her case, Denise, she was always adamant that she didn't want her spouse, Sharon, to make decisions for her in an end-of-life scenario. And she didn't want Sharon to be the executor of her will for her own reasons. And the patient herself, had never raised concerns about her son financially abusing her, and really stuck by her initial decision that her son Shane should be POA and the executor of her will when she passed. So, her other son, Dan, was upset. He was contacting social work and patient relations and the doctors and the nurses. But I think, it wasn't our role to start unpacking the past history within this family. It was more so our role to continue assessing Denise's capacity, and maybe, referring the son to seek legal aid, or for him to consult with an elder abuse line, and maybe encourage the family to pursue some family counseling that may have been long overdue. But, going back to that whole option of the calling police and flagging elder abuse. So in this case, Denise was capable when she assigned her power of attorney, and she continued to be capable. And she herself had no concerns. She never expressed concerns. We knew that there is strain with her sons, and maybe it's not ideal. Maybe, it would have been better if she was willing to assign Sharon, because it seemed that she had a more stable relationship with Sharon. But, people are allowed to make decisions, even though we perceive them as poor or less than ideal. So again, we need to consider, her history, her past challenges, her values, her culture, and the really long-standing dynamics that were at play.
Olivia, there's quite a bit happening in the chat box. So I'm going to try to do my best to figure out what came and when.
Yeah, I thought this would be a thought-provoking one.
Yeah, and I think this and the slide before, right? So if I'm understanding correctly, and people, if I mess this up, please let me know in the chat box so we can come back.
Mm-hmm.
But With regards to the poll, I think there was a suggestion from someone that a meeting could be held so everyone has an opportunity to say their piece.
Absolutely. Yeah.
Yeah, I think the other comments, as far as I can tell, are related to the slide before. So there's a comment that sometimes people pull back because they don't know what to do.
Hmm.
Does that make sense in terms of context of the previous slide?
I can switch it back. This one here.
Yes. The one before, yeah, I think this was, I think this was related to family conflicts.
Yeah.
So people pull back because they're not, they don't know what to do. That makes sense.
Absolutely. And there's discomfort, right? Like we all know that our loved ones are going to pass away, but when it happens or when it's going to happen, of course, people, that fight, flight, or freeze, some people don't know how to respond. So there's inaction.
Absolutely. Yeah, the next comment is, there's often the child who has not been around and comes in at the end and wants to change everything or not accept what is happening.
Yes. Yeah. Oh, you guys are speaking my language. Yeah, absolutely. And again, I think it's, if we're thinking of this case scenario with Denise, it's looking at our patient, like who's our patient? What's our goal here in care, right? And if the patient is capable, that's what we need to focus on.
Yeah, great reminder. Keep focused on the goal. Yeah. So the next is a question. Is the hostility and aggression towards staff possibly a fear response on the part of the family member?
Oh, that's such a good question. Absolutely. And I think fear is part of that grief response, right? Sometimes underneath anger and hostility, there's sadness. And of course, there's fear. So it kind of comes off as a defense mechanism in a way. It's not always pleasant to be on the receiving end, but even if you acknowledge that for somebody, just saying, for some people, strong emotions come up when there's a lot of sadness. How have you been feeling lately? Sometimes that can land well, other times not so much, but I think just acknowledging that and bringing that forward can be therapeutic.
That is a possibility. Yeah. So one last comment. Carmen has said, this is going back a bit, but you mentioned shared caregiving roles between family members.
Mhm.
Do you have advice for navigating the multiple opinions and diverse wishes of large involved families where there are multiple substitute decision makers, but also many other family members actively providing care, but not always privy to the personal health information or health decision making?
That's a great question. And I'm working on a case right now that, it sounds very familiar. It can be really tricky, right? I think in a perfect scenario, again, going back to the capacity, is this person capable? If so, they should be the leader. It should be, they should call the shots on their care. If not, you would hope that there's a power of attorney, that there's a legal document that explains, who that decision-making person would be. The substitute decision-making hierarchy can be tricky because the Substitute Decisions Act, like for example, if Denise had no power of attorney, she wasn't living with Sharon. So because it would still be a meaningful spouse. They're in a meaningful relationship. So I think Sharon would be her substitute decision maker if she was willing. If she was willing or unavailable for whatever reason, then it would be her adult children, but they would have equal decision-making say. But again, this is if she's not capable. If she's capable, then she should really be the leader of her care. When everybody, I think, is trying to step in and have their say, I think it comes down to basics, even if it's laying out okay, what are the aspects of care that we're trying to get a handle on? Is it logistics like transportation and appointment management and medication management and meals and housekeeping? Or is it more things like planning for the future and decluttering the home maybe, or, making sure that, our paperwork is in order, or maybe pre-planning a funeral, trying, I think, to sort out, what are all these decisions that we're trying to make? And if there's a way of even dividing, okay, I'll take these, you take these, you take these. But again, in really large families, it can be tricky just because of sheer volumes. But especially if communication was strained before, some people like organize themselves with like a family group chat or like a shared calendar. And that can help, get everybody on the same page. But again, like people have their different comfort levels and have their different access. If there's one person that doesn't have internet and they can't see the shared calendar, but you can get creative in terms of different strategies. But yeah, every family is different. It's really tricky stuff.
Absolutely. There's one other comment just around clarification of the SDM, the substitute decision maker. So Eileen's wondering if they've lived together for 2 years, it would be Sharon by the SDM hierarchy.
Yes. And I think you're absolutely right. I think I have my cheat sheet at work and I'm seeing it, but I
so
think
guardian is 1, power of attorney for personal care is 2.
Yeah. And if you haven't lived together.
Yeah. So number 4 is spouse or partner. So
Yeah.
that definition is quite broad as far as I understand, Olivia, right? In terms
Yeah. I think we'd have to, in a case like this, you'd look at the Substitute Decisions Act and you'd look at that hierarchy a bit more carefully. But again, the substitute decision maker would just be able to make health decisions, and they can't step in to make financial decisions.
Yeah, different power of attorney.
Exactly.
Shirley is confirming. We will trust Shirley. She says, yes, they have to be living together.
Okay. Yeah. Thank you. Yeah. Thanks for that reminder. That's one piece where I look at my cheat sheet.
Couple of other just quick comments. One person is saying this is all very good to know. And Crystal is just confirming that the SDM hierarchy is different in different provinces, correct?
Yes, that is correct. And the power of attorney documents are different from one province to the other.
Olivia, do you have time for one more?
Absolutely.
Okay. All right. So there are challenges where power of attorney is changed after the patient or resident loses capacity. This places the healthcare provider at huge risk. Family are at conflict, and the CCB, Consent Capacity Board, it takes time to assess for clarification.
And I think, if a power of attorney was changed after someone is no longer capable, then my question is like, how was it changed? Because the only person that can assign a power of attorney is the patient. So, this can, it can really get into the weeds here, but, the patient themselves can assign a power of attorney. If that power of attorney is not able to act as power of attorney, then you would go to the next person assigned or to the next, eligible SDM. But that person needs to be capable in order to change their power of attorney.
Legally, sure. Yeah, there's a further comment by the same original poster saying, except, I guess in her experience, lawyers have been known to do so.
Yeah. And yeah. I think seeking legal consultation, it can always be a good thing. And I think in one sense, it can help us as healthcare professionals if there is, that third party involved. But it does get tricky, especially if, let's say, the power of attorney that was assigned is not acting in the best interest, and if the physician has concerns about their capacity, then the CCB could be a factor that POA could refute their decision-making capacity at a CCB. It can really become really multidimensional. And I think this is where, you know, we consult with team. We don't take unilateral decisions, you know, we really expand, having, you know, the physician, the ethics, the neuropsych, if we have access to it, patient relations, and really, really, really properly documenting all the time to try to err on the side of caution.
Thanks, Olivia.
So what are our takeaways from today? I hope that, if anything, you know, teasing through examples of navigating difficult family situations, but from my lens as a social worker, offered you a different perspective, and that you can move forward in your work by continuing, you know, to reflect on coping styles and recognizing when a grief reaction is being had, recognizing when there's unspoken family rules at play, or when there's social determinants of health that have been a factor. Good reminder that, you know, active listening, our presence, and, you know, our compassion, they're really our most valuable skills as clinicians. And, you know, I think sometimes we underestimate how far simply just listening to somebody can go. We want to really normalize anticipatory grief and grief reactions, especially through advanced illness. And we want to acknowledge this and bring this at the forefront for patients and families, and acknowledge our own biases and our own expectations of patients and families. And I think, you know, in all the care that we provide, we can expect to be impacted. We do challenging work. It can be really rewarding and fulfilling and crazy making, and but, you know, there is a reason that we're in the professions that we're in. But I think, you know, we're human, and it's normal that we'll have emotional reactions to the challenges that the people that we work with. And of course, I wouldn't be a true social worker if I didn't share some practical resources. So my grief and kids' grief, like we were talking about earlier, and a few really great resources there. Canadian Virtual Hospice, the Learning Hub, Living My Culture is a really interesting resource they have. Well, the videos that you watched today were part of Living My Culture, and there's kind of how illness is approached in various cultures and people speaking about it from their perspective. And it can kind of help just with like educating ourselves. Of course, I think our patient and their families are our first line of defense, you know, talking to them and being curious with them, but this is also a really great tool. My references, few acknowledgements of support. A big shout out to Carl. He helped me with the formatting and with the Zoom polling. For me, it was really Zoom naive. Thanks for your time, everyone. Is there any questions or any things that we haven't touched on? Really appreciate your participation.
So there is a question: how to let go of these family conflicts with patients so I don't take it home to my own family?
Oh, yeah. I think, like, you know, I had heard a quote, like, how do you walk through the rain and come out dry? I'm saying the quote wrong, but just, you know, I think it's expected that we'll be impacted. We're humans, and these are really intense cases. I think if you're able to have some sort of wind down strategy, whether it's on your drive home or debriefing with a colleague, trying to have like a physical transition from work to home, you know, whether that's through music or through meditation or through movement, like exercise or a walk, but I think, giving yourself that time and also using that self-compassion piece, I think it's so key in our work and the care that we provide. Just acknowledging like, yeah, this was a really hard case and it's bringing up a lot of emotion for me. And with self-compassion, or with the mindful self-compassion, it's the 3 components, kind of acknowledging the challenge, using kind of that human connection piece, saying, a lot of my colleagues have challenging cases like this, or I'm not the only one to feel this way. And then kind of giving yourself that compassion, that giving yourself exactly what you're wanting to hear, what would you tell your best friend if they came to you with this challenge? You wouldn't say, oh, suck it up, you can just shake this off, get home and do what you got to do. You'd say, no, that was really tough, and you're doing the best you can, and you're human, and take it one thing at a time. So I think, yeah, doing that self-compassion piece and then trying to have a sort of wind out routine, but it's not easy.
Thanks, Olivia. Those are so many great tips and good reminders. And if you can't see the chat box, there's like an endless stream of thank yous for the excellent presentation and the information and how meaningful it's been, and insight. Someone has shared that it's comforting to know they're not the only one dealing with large, complex family dynamics. And this last one, heartfelt presentation. So lots of thank yous.
Yeah, well, thank you, everyone. And I'm happy to have participated with you all. I'm honored to have been here today, and you have my contact there if you're ever wanting to troubleshoot or connect, and you'll have copies of the PowerPoint. There's not a lot of information on the slides themselves, but you'll have the resources and the gist of it. But yeah.
Absolutely. And I just want to remind everyone, I just put the link to the post-session survey in the chat there. So when you have a minute, or if you have a minute tonight, you can click on that and it'll bring you there. You can fill it out. And it's really how we base these sessions, is on the feedback from that. And so, yeah, we really appreciate you coming out tonight and filling that out. I just, someone else mentioned, I like how they worded this. I felt so unalone to have been part of this group. Very nourishing.
Oh, I love that.
Unalone.
Yeah, and your comments and participation made me feel unalone. So thanks to everyone.